Morning, everyone. I think this is a good time to get started to introduce Dr. Matt Paz, who is, as most of you know, is one of our current senior residents and is on his way to starting his GI liver pathology fellowship in July. So Dr. Paz completed his Bachelor of Science undergraduate degree right here at the University of Minnesota in 2021, and then in 2017, and then between 17 and 2021, he went to the Kansas State University where he did Doctor of Osteopathic Medicine. After that, he ranked with us as an APCP pathology resident from 2021. And there's so many things I can say about Matt as a resident over the years, all great and good things. But I think most of the quite impressive things that I've observed is that in the 4 years that he's been here, less than 4 years, Matt has, presented about 7, maybe 8 abstracts at national meetings. So that comes to almost like 2 abstracts a year. And I think that is quite impressive. And I know that he has about 2 or 3 coming up in March later this year. So that, I think, summarizes, Matt's dedication to his work and his love of pathology. And it's just been a pleasure to call myself one of Matt's teachers. Recently, he won the second premium ribbon at the 2024 Minnesota State Fair, where he has been a constant presence for the last 2 or 3 years. So this year morning, we're going to be listening to Matt as he's going to be talking to us about extracutaneous melanoma. So Matt, over to you.
Thank you for the introduction, Dr. Day, and good morning, everyone. Today, I will be giving my grand rounds talk on extracutaneous melanoma. I have no financial disclosures for this morning. These are my objectives, and I would like to preface my talk with my personal perspective and thoughts on melanoma and non-melanoma skin cancers. So this is Puerto Galera, one of the beaches in the Philippines where I grew up. We were in the Philippines. We were fortunate enough to be close and have easy access to these beautiful beaches every summer. We would often visit multiple beaches or summer resorts in a single week. And as an unfortunate consequence, a lot of us would get these sunburn. For us, especially children, sunscreen was really an afterthought. And the reason for this may be because there is a lack of visibility of skin cancers among Filipinos. This quotation on the slide is from a physician I spoke with several years ago when I shadowed in the Philippines, which when he mentioned that when I was asking about the incidence of skin cancers in the Philippines, he clarified that the incidence is so low that it might as well be negligible. This is unfortunately very inaccurate. And a study by Wen-Chen Chang and colleagues on melanoma in Asia, they note that melanoma, while the incidence of melanoma in East and Southeast Asia is low, it is not non-existent. In a separate study by Tan and colleagues for non-melanoma skin cancers, they noted around 2,100 basal cell carcinomas and approximately 600 squamous cell carcinomas in the Philippines documented between 2011 and 2021. They also note that there is a lack of national cancer registry, and therefore these reported counts are likely undercounting the actual cases in the country. Despite the low incidence of melanoma and non-melanoma skin cancer in East and Southeast Asia, it is important to realize that about 1/3 of the global population is in the region, highlighting still a significant disease burden for both melanoma and non-melanoma skin cancers. Furthermore, melanoma among Asian patients tend to present with a more advanced disease stage compared to Caucasian patients. Reasons for a more severe presentation at time of diagnosis are multifactorial. One, as I alluded to earlier, is a lack of awareness of skin cancers. There appeared to be an over-reliance on inherent photoprotection. Tan and colleagues in their study noted that the unfortunate exposure of some individuals working in agriculture exposed them to cumulative UV exposure that overcomes the inherent photoprotection with the inherent skin pigmentation among Filipinos. Wan Chen Chang and colleagues also note that different melanoma subtypes, that is non-UV associated and extracutaneous melanoma, are more prevalent among Asians, particularly acral and mucosal melanomas. With that, I will now focus my talk and continue on with the topic for today, that is melanoma and ultimately extracutaneous melanomas. Melanoma is a malignancy of melanocytes. It has a tendency to metastasize even at a small number of tumor cells, and thus it is the deadliest of skin cancers. However, it can be cured if detected and treated early. It most commonly arises in the skin, but other sites of origin include the oral and anogenital mucosal surfaces. Improved public awareness increased surgical cure rates of cutaneous melanoma, but the overall reported incidence of melanoma is increasing. There are several pathways and the pathogenesis of melanoma shown on the screen is one pathway involving the progression from a non-invasive benign nevus to metastatic melanoma. There are also multiple genetic alterations, some of them similar, shared between different melanoma subtypes. However, the sequence of and the exact alterations between these subtypes may not be the same. An estimated 325,000 new cases, there were 325,000 new cases of melanoma noted in 2020, accounting for 1.7% of global cancers, according to the Global Cancer Observatory. The age standardized incidence is 3.8 per 100,000 for men and 3 per 100,000 among women, with a cumulative lifetime risk of 0.42 and 0.33 respectively. One caveat about these data, however, is these surveillance data may be inaccurate, especially in countries without national cancer surveillance programs such as the Philippines. According to the latest SEER data, melanoma is the 5th most common cancer in the United States, excluding non-melanoma skin cancers. It is particularly prevalent among Caucasian males, with a reported incidence per 100,000 individuals of 34.7 and 22.1 among men and women, respectively. In comparison, the incidence is 1.0 and 0.9 per 100,000 individuals among African American men and women, and 5.0 per 100,000 among both sexes among Hispanics. The mean age at diagnosis is 65, with a 65.7% of among these made between ages 55 and 84. This figure from a review article by Saginala and colleagues highlight a map showing estimated age standardized incidence rates for melanoma worldwide as compiled from the Global Cancer Observatory data in 2020. Globally, the incidence of melanoma has increased. For example, in the United States, there has been a 320% increase between 1975 and 2018. Reported incidence rate in other countries such as the United Kingdom and Australia mirror these increase in incidence. An estimated 57,000 people died of melanoma in 2020. According to the Global Cancer Observatory age standardized mortality, according to the Global Cancer Observatory, this results in an age standardized mortality of 0.7 per 100,000 individuals among men and 0.4 per 100,000 individuals among women. In the United States, the mortality rate was 2 per 100,000 in 2018, which is lower compared to 2.8 per 100,000 individuals in 2009. Among Caucasian men and women, the mortality was 3.9 and 1.7, respectively, compared to 0.4 and 0.3 per 100,000 individuals among African American men and women. Overall, melanoma accounts for over 80% of skin cancer deaths. Among Caucasians in the United States, mortality from melanoma increased by 7.5% from 1986 to 2013. However, since 2013, this has decreased by 17.9% with the advent of new targeted immunotherapy treatments. That is the 5-year survival data from 2011 and 2017, according to SEER, is 93.3%. This is up from 81.9% from 1975, which was the first year when the 5-year survival date was recorded. The 5-year survival is 99.4 among those with stage 1 to 2 disease, decreasing to 68% for those with stage 3 and 29.8 for those with stage 4. However, only 4% of patients are diagnosed with stage 4 disease, with 83% of patients being diagnosed with stage 1 to 2 disease. These are some of the risk factors for melanoma. UV exposure is the primary risk factor, and this is modulated by genetics, and the UV wavelength, that is UV wavelength. The first two in these, sun exposure and indoor tanning, are directly associated with UV exposure. UV light is known to induce different DNA photoproducts, particularly thymine dimers, which, if unrepaired by nucleotide excision repair, cause downstream errors in DNA replication. The location of UV-induced mutations, that is the cancer profile, also vary highly with the melanoma subtype, prognosis, and the response to treatment. Some of the most commonly mutated proteins in melanoma are members of the mitogen activated protein kinase, the MAP kinase, such as NRAS and BRAF. Other risk factors include immunosuppression. This may be somewhat associated with UV exposure. UV radiation has been known to decrease immunosurveillance by Langerhans and dendritic cells, thus impairing the activity of T cells and NK cells against aberrant melanoma or melanocytes. Beyond UV association, the association of a melanoma and immunosuppression may explain the effectiveness of immune checkpoint inhibitors in the management of the disease. Moles or nevi are also known risk factors for melanoma. They are benign growths of melanocytes and are considered both direct precursors and markers of increased risk for the development of melanoma. About 10% of patients with melanoma have a family history, though only a few congenital syndromes have been characterized. One example include dysplastic nevus syndrome, which is a rare congenital disease of atypical nevi associated with increased risk of melanoma of the skin, as well as rare locations such as the gallbladder. It is associated with neurofibromatosis type 1, as well as other endocrine disorders. Other hereditary melanomas include congenital melanocytic nevi, and these patients are born with an increased risk to develop many large moles, which put them at increased risk for neurocutaneous melanocytosis and melanoma. These patients often have mutations in NRAS. Finally, obesity. Some melanoma incidents have been associated with obesity, with some studies noting an increased risk among those patients with a BMI of over 30. Melanoma traditionally has been classified according to the histopathologic and clinical features based on the proposal by McGovern and Clark. Recent advances in molecular genetics allowed for the cataloging of genetic alterations, and the integration of these data allowed for the further refinement of melanoma classification, which was noted in the WHO classification of skin tumors. In the 5th edition of the WHO classification of skin tumors, melanoma is divided according to 9 pathways, which are broadly grouped between UV radiation and non-UV radiation melanomas. UV radiation-associated melanomas include low CST, that is cumulative sun damage, high CST melanomas, and desmoplastic melanomas. These melanomas, according to a review by Long and colleagues, are comprised of 75% of cutaneous melanomas among Caucasian Americans. Global lifestyle changes as well as atmospheric changes has increased UV exposure, and in parallel has led to an increased incidence of UV radiation-associated melanomas. UV radiation-associated melanomas occur in sun-exposed areas of the skin and are common among individuals with light skin tone and poor tanning ability. Low and high CSD melanomas are defined by the degree of background solar elastosis. Low CSD melanomas tend to be diagnosed in sun-exposed areas such as the back and are often diagnosed among patients younger than 55. Common genetic alterations include BRAF V600E and additional alterations in CDKN2A and DERT promoters. High CSD melanomas are associated with a severe background solar elastosis. They are often diagnosed in chronically sun-exposed skin and among patients older than 55. Neoplastic cells in these melanoma often have a lentiginous pattern, and common genetic alterations include BRAF V600K, biallelic NF1 inactivation, and RAS and KIT mutations. Desmoplastic melanoma lastly, are rare and present as sarcomatoid spindle cell neoplasms arising from a radial growth phase of lentigo maligna. They're often associated with severely sun-damaged skin with a very high associated mutational burden. NF1 inactivating mutations are the most commonly encountered genetic alterations. Non-UV radiation-associated melanomas are those melanomas arising from sun-shielded areas or without a known etiological association with UV radiation exposure. These include Spitz melanoma, which tend to occur in younger patients, tend to have a better prognosis and often harbor distinct genetic alterations such as HRAS, kinase fusions and ROS, CDKN2A inactivation, and TERT promoter mutations. Acral melanoma occur in glabrous skin and nail. Again, they are not associated with any UV exposure risk, though chronic trauma appears to be a potential risk factors. Alterations associated with these melanomas include CCND1 and TERT amplifications, as well as in KIT and RAS and NF1. Mucosal melanomas, similar to acral melanomas, have no etiological relations with sun exposure. They have a low mutational burden but exhibit focused amplifications and other rearrangements, highlighting their genomic instability. Melanoma arising from congenital nevus are initiated by somatic MAP kinase mutations and are often involve of other mutations in MAP kinase. Melanoma arising from blue nevus show GNAQ and GNAS mutations and similar to uveal melanomas. Uveal melanomas arise from melanocytes of the choroid. Melanocytes of the choroid. Not listed here, but I will also briefly discuss. CNS melanomas arise from leptomeninges and are linked with congenital nevus syndrome. Like uveal melanomas and melanomas arriving from blue nevus, they also harbor alterations in GNAQ and GNAS. Other classification systems for melanoma have been proposed using various axes of histopathologic, genetic features, and organ systems of origin. For simplicity's sakes, for the rest of the presentation, I will use these 9 pathways that were listed in the 5th edition of the WHO Blue Book. I will further focus the remainder of today's talk with extracutaneous melanoma, which I will define as mucosal melanoma and uveal melanoma, excluding melanomas arising from acral skin and from nevus. While I will not discuss these other melanoma, they tend to, as I briefly alluded to earlier, they tend to harbor similar genetic alterations with some of the melanomas I will be discussing, such as blue melanomas and uveal melanomas arising from blue nevus and uveal melanoma. Continuing on with extracutaneous melanoma, these melanomas tend to have a more aggressive outcome compared to non-acral cutaneous melanoma, with patients having a more poorer outcome. Part of these poor patient outcome may stem from management recommendations being based from data extrapolated from experience with management of cutaneous melanoma. Ongoing research, however, has led to the development of several ongoing treatments. Mucosal melanoma is one of these extracutaneous melanoma. These are rare, comprising of about 0.3% of new cancer diagnoses and 1.4% of all melanomas in the United States. The incidence of mucosal melanoma has remained stable compared to the incidence of cutaneous melanoma over the last 4 decades. They arise from melanocytes in the gastrointestinal, respiratory, and urogenital tracts. Melanocytes originate from neural crest cells and have the property to migrate not only under the epidermis, but also at the basal layer of the epithelium at various anatomic districts. Melanocytes can generally be found nearly in all tissues at varying degrees. This table from an article by Carvajal and colleagues highlights the most common anatomic sites for the occurrence of mucosal melanoma, highlighting that they are most common in the head and neck and least common in the vulvovaginal or urogenital areas. Mucosal melanomas have a higher rate among women at 2.8 compared to 1.5 cases for men per 1 million individuals. They tend to occur among older patients with a median age of 70 at the time of diagnosis. One important feature for mucosal melanoma is the varied incidence rate among different ethnic groups. The disease is rare among Caucasians, and as I alluded to earlier, they are very common. They are common among Asians, comprising 39.6 of all melanoma cases. They're also more common among African Americans and Hispanic populations, comprising 10% and 4% of melanoma cases, respectively. In contrast to cutaneous melanomas, advanced disease is often found at the time of diagnosis. To highlight a typical or an example clinical presentation of mucosal melanoma, I will present a clinical case of a gastrointestinal melanoma we encountered here at the university. Our patient is a 61-year-old Caucasian woman with long-standing anal lesion. This was long thought to be a hemorrhoid. However, the patient presented for follow-up in 2017 after it became painful. A biopsy was subsequently performed, which revealed that the lesion, unfortunately, is melanoma. Here we can see it is mitotically active, and immunohistochemical staining with melan A is shown to be, or the tumor is shown to be diffusely positive for melan A. The patient underwent initial imaging, which showed FDG avid lymph nodes in the region, but did not show any evidence of metastasis. The patient was treated with transanal resection and adjuvant nivolumab, but unfortunately, the patient eventually developed brain metastasis, subsequent cognitive decline, and passed away. This table from Carvajal highlights some of the initial clinical presentations of mucosal melanoma at different anatomical sites, and it mirrors some of the symptoms presented by our patient, including suspicion of hemorrhoids. Briefly going over the clinical presentation of mucosal melanoma at these various sites. In the head and neck region, a mucosal melanoma may be found either in the oral cavity or in the upper respiratory tract. In the upper respiratory tract, mucosal melanoma may occur either in the nasal cavity or in the sinonasal region. Nasal cavity melanomas tend to be diagnosed earlier and often have a more favorable outcome compared to sinonasal melanoma. A pooled 5-year analysis, 5-year survival rate comparing sinonasal melanomas and nasal cavity melanomas show a 31% for nasal melanomas and 0% for sinus melanomas. Both of these melanomas tend to metastasize, usually to the liver and lung, with nodal involvement present in 20% of patients at the time of diagnosis. Some of the symptoms patients present with include epistaxis, rhinorrhea, and other symptoms showing nasal obstruction. Oral melanomas, in comparison, are often diagnosed early because of its easy accessibility. They may present as a polypoid fleshier, as a pigmented, rapidly growing mass with varying stages of pigmentation. Distant metastasis, while local metastasis may be present at the time of diagnosis, distant metastases tend to be rare at the time of diagnosis at 5 to 10% for both oral and sinonasal melanomas. Gastrointestinal melanomas, in contrast, are comprise approximately 37% of mucosal melanomas. Of these, the anorectal tract is the most common, comprising of more than 50% of all gastrointestinal melanomas. This is followed by the stomach, the small intestine, and the colon. However, anorectal mucosal melanomas are still very rare, accounting for approximately 0.5% of all colorectal and anal cancers. Mucosal melanoma of the rectum is more uncommon compared to anal mucosal melanomas, but they tend to be lumped and studied together as a single entity. They are most frequent in women aged over 50 and are characterized by a very poor prognosis. Typically, some of the symptoms a patient may present with include itching and rectal pain, and unfortunately may be mistakenly attributed to a benign pathological entity, leading to it being ultimately diagnosed at a later stage. Moreover, if the patient presents with a more noticeable symptoms such as changes in bowel habit, bowel obstruction, or rectal bleeding, the disease has already progressed to a more advanced disease stage. Finally, least common among mucosal melanomas include the genitourinary tract mucosal melanomas. Among these, they most commonly occur in the female genitourinary tract at 90%, and least commonly in the urinary tract at 4%. In the female genitourinary tract, it most frequently involves the labia minora and followed by the labia majora, and least commonly in the urethra and the cervix. Some of the symptoms include itching and vaginal discharge, and ultimately the prognosis for these are poor, owing to early lymph node and distant metastasis due to the rich lymphatic drainage of the region. Male genitourinary tract melanomas typically present as a pigmented lesion or ulcerated lesion in the glans penis. The prognosis for these is also poor, again, mirroring the rich lymphatic drainage and metastatic potential of these melanoma. Least commonly, the urinary tract melanomas involving either the urethra or the bladder. These patients may present with hematuria or urinary obstruction. Again, these tend to have poor prognosis. Overall, all the genitourinary mucosal melanomas tend to be very aggressive with a propensity for early lymphatic and metastatic spread. The pathogenesis for all the mucosal melanomas remain incompletely elucidated, though different recent discoveries have found aberrant intracellular signaling pathways. Historically, patients with mucosal melanomas have substantially poor outcomes compared to patients with cutaneous melanoma, with a 5-year survival of 80% compared to 25% of 80% for cutaneous melanoma compared to 25% for mucosal melanoma, respectively. This finding is attributable to high rates of advanced disease at the time of diagnosis. The 5-year survival also differed for patients with mucosal melanoma, depending on the site of the anatomic site. Head and neck, gastrointestinal, and urogenital mucosal melanomas have an associated 5-year survival risk of 31.7%, 20%, and 11.4%, respectively. As mentioned earlier in the talk, mucosal melanomas tend to have fewer mutations compared to cutaneous melanoma. Colombina and colleagues posits that this may be due to an early but extensive chromosomal rearrangement, such as chromothripsis, as shown in this figure from the paper by Colombina and colleagues. Mucosal melanoma tend to have a whole genome sequencing study of mucosal melanoma and cutaneous melanoma show that mucosal melanoma tend to have 8,000 somatic single nucleotide variants per genome compared to 30,000 in cutaneous melanoma. This figure from an article by Sautefania summarizes some of the involved pathways in melanoma. This in particular is the MAP kinase pathway. Mucosal melanoma and cutaneous melanoma tend to share alterations or tend to impact the same pathways. However, in contrast to cutaneous melanomas, where the actual components of the pathways such as NRAS and BRAF are more commonly affected, mucosal melanomas tend to impact the signal trans tend to impact effectors external to the pathway, such as KIT or NF1. In order to investigate other potential diagnostic and prognostic markers, specifically for gastrointestinal melanoma, we actually conducted a retrospective analysis of metastatic and primary gastrointestinal melanomas here at the university, which we are going to be presenting for the upcoming USCAP meeting. We are also concurrently putting together a manuscript for the project. So for our study, we reviewed our AP Beaker as well as Info Archive, looking at the 20-year, looking at gastrointestinal melanoma cases over the past 20 years. Briefly summarizing our findings, we identified 35 cases of melanoma involving the luminal GI tract. We excluded any melanomas that metastasized solely to the liver. 26 of these are metastatic and 9 are primary. These are a similar case profile to another 20-year retrospective analysis on GI melanomas conducted by La Salva and colleagues. Immunohistochemical stains were performed in 27 of the 35 cases. 23 had BRAF testing performed. 15 had further NGS testing performed. Of these, of the cases with BRAF testing performed, 4 cases had BRAF V600 alterations, and 2 primary mucosal 4 metastatic melanoma cases had BRAF V600 mutations. 2 mucosal melanoma cases had non-V600 BRAF mutations. Of the patients with NGS testing performed, we identified 4 cases with KIT mutations. 3 of these were identified in primary mucosal melanomas. We identified 6 cases with NRAS mutations equally for both equally in primary and mucosal melanomas. Other pathogenic variants we identified included TP53, SF3B1, STK11, and P10 mutations. Summarizing our findings for both immunohistochemical and molecular profiles, both metastatic melanomas and mucosal melanomas have similar immunohistochemical profiles, being positive for melon A, S100, and SOX10. Roughly equal number of cases, equal number of primary mucosal melanoma and metastatic melanoma express NRAS. BRAF V600 mutations, both V600E and V600K, were solely identified in our data set in metastatic melanoma. KIT mutations were mostly identified in primary mucosal melanomas. I believe our findings are in line with the findings noted in this meta-analysis by the Cancer Genome Atlas. In this figure by Santifemia and colleagues, they note that gastrointestinal mucosal melanomas tend to most frequently harbor KIT mutations compared to NRAS and BRAF. Briefly going over some of the other pathogenic variants we identified. TP53, it's interesting because it is a tumor suppressor that is commonly lost in cancers. However, in melanoma, it appears to be often retained. It appears to be implicated paradoxically in driving tumor survival. Studies knocking down TP53 slow down melanoma growth, contrary to its tumor suppressor role. This may be due to its aberrant phosphorylation, leading to a failure to regulate downstream signaling pathways. Wild-type TP53 appears to be associated with the Wnt pathway and promoting a slow cycling phenotype, which is resistant to chemotherapy. SF3B1 is involved in spliceosome assembly. It is implicated in hematologic neoplastic processes. Recently, in in melanomas, it has been associated with uveal and mucosal melanomas, particularly in the female genital and anorectal mucosal melanomas. Its relevance to melanoma isn't clear, but it has been hypothesized to be a driver for tumor metastasis. STK11 is a tumor suppressor associated with metabolism and cell motility. Germline mutations in this for STK11 is associated with Peutz-Jeghers syndrome. It is associated with metastasis among epithelial malignancies, and in cutaneous melanomas, its loss is associated with reduced sensitivity to BRAF inhibitors. In BRAF and NRAS mutated melanomas, STK11 is associated with an increased invasiveness. In zebrafish models, STK11 loss is also associated with increased metastatic potential. Finally, PTEN is a tumor suppressor that regulates the cell cycle. It is associated with Cowden syndrome and is one of the most common genes altered in sporadic cancers. Ectopic expression of PTEN and PTEN deficient melanomas reduce tumorigenicity and metastatic potential. Management of mucosal melanoma includes surgical management, radiation, and systemic therapies. Surgical management is the primary treatment for localized and locally advanced disease. However, despite local control, more than 50% of patients with mucosal melanoma go on to develop distant metastasis. Radiation, that is both adjuvant and definitive therapy, has been used among patients with locally advanced disease, especially for those whom resection is not feasible. However, while adjuvant therapy, radiation therapy can provide additional benefit of local control, it has not influenced overall survival. For advanced disease, systemic therapy has been various systemic therapies have been used. Adjuvant systemic therapy for mucosal melanoma has been limitedly studied, but there has not been established standard of care for Western populations. There are, however, several studies that are being conducted, including a randomized phase 2 study in China showing significant survival benefit for adjuvant chemotherapy comprising of temozolomide and cisplatin. Targeted therapies have also been used. BRAF mutations are less common in mucosal melanomas compared to cutaneous melanomas. However, for those patients with BRAF alterations in their melanomas, BRAF inhibitors have shown modest benefits. KIT inhibitors for KIT for melanomas harboring KIT mutations are also being investigated, with larger studies being needed to confirm their efficacy. Immune checkpoint inhibitors are also being explored for mucosal melanomas, including three therapies that are approved include ipilimumab, pembrolizumab, and a combination ipilimumab and nivolumab therapy. While immune checkpoint inhibitors have expanded therapeutic options for mucosal melanoma, the outcomes remain less favorable compared to mucosal the outcomes for mucosal melanoma tend to be less favorable compared to cutaneous melanoma, necessitating further research. The reason for a less favorable response rate for immune checkpoint inhibitors among mucosal melanoma compared to cutaneous melanoma is not clear, but it is hypothesized to be due to a result of a lower proportion of mucosal melanoma harboring high levels of PD-L1 expression. Other therapies under investigation for the management of mucosal melanoma include various therapies involving VEGF inhibition, including those in combination with PD-1 blockade. Other potential future therapy targets include metabolic reprogramming, the targeting of microRNAs, as well as the adoption of mRNA vaccine technology, which has been used for the COVID vaccine. Shifting gears to uveal melanomas. Uveal melanomas are the most common intraocular malignancy, accounting for 85 to 95% of primary intraocular malignancies and 3 to 5% of all melanomas. They arise from melanocytes within the uveal tract, as seen as this figure, frequently in the choroid, comprising 90% of uveal melanomas. The incidence of uveal melanomas remained stable over the last 4 decades, with an age-adjusted incidence rate of 4.3 to 5.2 per million individuals. Risk factors include light-colored skin, fair skin, the presence of dysplastic nevi, or having cutaneous melanoma. BAP1 mutation is also a risk factor. Despite the similar patient risk factors with cutaneous melanoma, the role of UV exposure in uveal melanomas is unclear. Uveal melanomas tend to be asymptomatic at the time of diagnosis, with lesions being identified on routine eye exams. Clinical features typically in patients with clinical symptoms. These typically manifest as vision symptoms, including visual field loss, blurred vision, or eye pain. Diagnosis may be made on fundoscopic examination, coupled with advanced testing techniques such as ultrasonography or optical coherence tomography. Uveal melanomas have a unique mutational profile compared to cutaneous melanoma, acral melanoma, and even mucosal melanomas. They tend to occur predominantly in the macular area, correlating with light dose distribution. Metastasis or local treatment achieves low recurrence rate, but metastatic disease occurs in over 50% of patients. And these, approximately 90%, involves the liver. This is driven by the hematologic spread and factors such as c-Met and CXCR4. Other sites secondarily involved by metastasis include lung, bone, brain, lymph nodes, and skin. Uveal melanomas often have both early and late recurrences. Unfortunately, 20 to 30% of patients die of systemic disease within 5 years. Uveal melanomas harbor cytogenetic markers such as chromosome 3 loss and 8q rearrangements. Other abnormalities such as 1p, 6q, and 8p rearrangements correlate with poor outcomes and high risk of distant recurrence. Different from other tumor types, the presence of an inflammatory infiltrate is associated with poor prognosis for uveal melanoma. This previous studies highlight or suggest that the tumor microenvironment in uveal melanoma may be immunosuppressive. In the largest evaluation of primary uveal melanoma tumors, comparing copy number alterations, mutations, and gene and protein expressions, highlight this by the TCGA project. They identified, as I alluded to earlier, that uveal melanoma have distinct molecular features compared to cutaneous melanoma, mucosal melanoma, and acral melanomas. GNAQ and GNA11 are found in more than 90% of cases, typically at the Q209 position. In patients with wild-type GNAQ, PLCB4 and CYSLTR2 are commonly seen. Furthermore, somatic SF3B1 and EIF1AX mutations are associated with good prognosis, while alterations in BAP1 are associated with poor outcomes. This table 3 from Carvajal, summarizes the distinct molecular and genetic features leading to different clinical subtypes for uveal melanoma. Management for uveal melanoma echoes that in those in mucosal melanoma and includes surgical management, radiation therapy, and adjuvant therapy. For surgery, enucleation was the standard of care until the 1970s when alternative therapies emerged. Nowadays, enucleation is reserved for patients with large tumors, especially those patients exhibiting complete vision loss. Various radiation therapy modalities are applicable for the management of uveal melanoma, including brachytherapy, stereotactic photon therapy, and laser-based therapies. The treatment modality of choice depends on the tumor size, location, and patient-specific factors. Late toxicities and recurrence risks vary across the vary across these methods, influencing long-term outcomes. Adjuvant, there are several adjuvant therapies that are available for the management of advanced uveal melanoma. Historically, dacarbazine and interferon have been used. However, unfortunately, these show no survival benefit for high-risk uveal melanoma. Several studies are ongoing for targeted therapies, such as those inhibiting c-Met, EGFR, and IGFR. Therapies targeting BAP1 mutations are also under evaluation. Immune checkpoint inhibitors, similar to mucosal melanomas, are being tested. And a study examining ipilimumab show a median distant metastasis-free survival of 4.6 years. For metastatic uveal melanoma, most therapy targets include liver-directed therapies, including resection, radiofrequency ablation, and stereotactic radiotherapy. Other novel treatment options for uveal melanoma include IMC GP100, which is a bispecific biologic targeting T cell receptors and GP100. Because of high rates of downstream activation of MAP kinase, several studies examining targeted inhibitors of this pathway is also being evaluated. Furthermore, DNA methylation or histoacetylation in uveal melanoma may be a pathway for oncogenesis and may be a possible target for therapy. For example, bromodomain and extraterminal protein inhibition targeting the BET family of proteins are being investigated. Next, briefly talking about primary CNS melanomas. These are melanomas arising from melanocytes of the meninges. These are very rare, comprising approximately 1% of all melanomas and up to 0.07% of all brain tumors. Because of its location, diagnosis is difficult. A majority of patients present with raised intracranial tension or other neurological deficits. Purely intraparenchymal location of melanoma is highly indicative of a metastatic disease compared to a primary CNS melanoma. Similar to highlighting, again, echoing its similarity to uveal melanomas, primary CNS melanoma tend to harbor alterations in gene AQ, gene 11, PLCB4, and CYSLTR2. The alterations in these genes are considered the first step in oncogenesis of meningeal melanocytic tumors. In children, it tends to occur primarily in patients with neurocutaneous melanosis. Unfortunately, primary melanoma of CNS has a very poor prognosis, particularly among children. Mutational analysis and methylation profiling are important in the diagnosis of CNS melanoma in order to differentiate it from metastatic melanoma. Identification of BRAF and RAS-occurred mutation are suggestive of a metastatic cutaneous melanoma versus a primary CNS melanoma. The presence of a gene or GNA11 mutation in the absence of uveal melanoma or a blue nevus-like melanoma strongly favor a primary CNS tumor. In this, in a review paper by Guo and colleagues, they highlight the most common molecular markers in CNS melanoma compared to uveal melanoma and cutaneous melanoma. This pie chart A and pie chart B are more similar, with pie chart A being representing CNS melanoma and B representing uveal melanoma, respectively. In contrast, C highlights the most common molecular alterations in cutaneous melanomas. There are no specific guidelines that exist for the management of primary CNS melanomas. Conventional treatment of CNS melanoma include surgery for early tumors as well as radiotherapy for radiotherapy for incompletely resectable tumors. Currently, chemotherapy regimens for CNS melanoma have not been standardized, and clinical practice relies on the physician's experience with similar cases. Temozolomide, dacarbazine, and other platinum-based drugs, as well as intrathecal methotrexate, are commonly used. There are targeted therapies under investigation, particularly against GNAQ and GNA11. Immunotherapy has shown promise, but currently only a few cases of CNS melanoma have been treated using these therapy modalities. Briefly going over metastatic melanomas, that is melanomas at any site of origin presenting at an extracutaneous site. Because of melanoma being of neural crest origin, they express multiple signaling molecules that promote their metastasis. When they are metastatic, the metastatic lesions may present similarly to primary extracutaneous melanoma, depending on the site. However, their molecular markers tend to reflect the primary tumor. Management of metastatic melanoma depend on the stage. Oligometastatic disease is managed by metastectomy, radiotherapy, as well as talimogene laherparvec. Widely metastatic disease may be managed with systemic therapy, including targeted therapies such as BRAF inhibitors and checkpoint inhibitors. With that, summarizing my talk today, melanomas, malignancy melanocytes, they are classified between UV and non-UV associated groups. Non-UV associated melanomas include extracutaneous melanomas. They tend to follow a more aggressive clinical course compared to cutaneous melanomas. Mucosal melanomas are rare and may arise from respiratory, gastrointestinal, and urogenital tracts, with clinical presentation depending on the site of the lesion. They exhibit distinct molecular markers compared to cutaneous melanomas, and management includes surgery, radiotherapy, and systemic therapies, with other therapy options and modalities under investigation. Uveal melanomas are the most common primary intraocular malignancies. Patients are often asymptomatic at the time of diagnosis, but may present with vision symptoms. In contrast to other malignancies, an inflammatory infiltrate is a marker of poor prognosis. GNAQ and GNA11 mutations are found in 90% of cases. Management includes surgery, radiotherapy, and systemic therapies. Primary CNS melanomas are rare. They share molecular alterations with uveal melanomas. Surgery and radiotherapy are used in the management of early CNS melanomas with systemic treatments, including immune checkpoint blockade used in advanced disease. Finally, melanoma exhibit multiple signaling proteins promoting metastasis. Metastatic lesions may mimic the clinical presentations of primary melanoma, extracutaneous melanoma. Management of oligometastatic disease include regional treatments, and systemic for widely metastatic disease include various systemic treatments. These are the references I used for today's talk. I would like to briefly acknowledge Dr. Ariba Rizvi, who has helped polish my abstract for USCAP and help review my slides for today's presentation. Dr. Andrew Nelson, who helped review our molecular data for our project. Dr. Amin, who presented a case of rectal melanoma, which served as the genesis for our USCAP project. Dr. Adei, who helped guide the study design for the USCAP project and has also reviewed my slides for today's talk. All our faculty, pathology faculty, AP and CP, for all the learning over the past 4 years, and my co-residents as well. And I would like to open myself to questions. This is me and my group of friends doing the glycoman pose in Osaka during our Japan trip last month. Thank you.
Yeah, that was cool. And thank you very much, Matt, for an excellent review and overview. So that was very nice. We have about 5-6 minutes for questions, and I know that Dr. Nelson has one. So, Andy.
I actually don't, Deli.
No, okay. I never knew that was possible. Thank you.
That's funny.
Okay, any question from anyone? So, Matt, I have a quick one. So you looked at those 9 cases and you saw some other mutations, including the STK11.
Mhm.
So where do you plan to go with that? Do you think there's something new there that if you increase the number of your subjects, there might be something unique about the GI mucosa melanoma, or you think this is just a random incident?
I started looking at STK11 and what's been written in melanomas, actually, Dr. Ade. For what I read, there was one published paper on STK11 and melanoma, but it's only on cutaneous melanoma. They
Yeah.
seem to suggest that it's associated with increased invasiveness and metastatic potential.
Hmm.
But so far, we on our data set of the primary mucosal melanomas, only one of them had the STK11 mutation, and it's also the case with the SF3B1 mutation. Both appear to be associated with increased invasiveness and metastatic potential. Interestingly, the case I presented is actually that case with harboring the STK11 and SF3B1, and unfortunately the patient did poorly. So it might be an interesting alteration to investigate further. Unfortunately, we do not have the
Yeah.
number of cases to look at.
Yeah. And I don't think there's any data to suggest that patients with Prosgegas have increased incidence of melanoma, is there?
I have not seen, or I have not dug into if there's any association between Peutz-Jeghers and melanoma.
Okay. Because that might give you some insight into whether that is just like a random thing or something to pursue further. So thank you very much. Any more question or comments? So
I have a quick question. This is Alessio.
yeah, let's go ahead.
Hey, Matt, a very nice presentation. I may have missed it, but these 9 cases of primary mucosal, over what time period do you find these 9 cases?
It's from the past 20 years, from 2014
20 years.
to 2020.
Wow.
Yes.
Okay. And another question, do you know if in any of these primary mucosal they look for EWSR translocation for clear cell sarcoma?
I don't think so. A lot of more than half of the primary mucosal melanomas were, especially the older ones from early 2000s, did not even have any NGS testing performed.
Yeah. And I think that's a very good point for clear cell sarcoma and everything. And you can still, I think, and I don't know if, again, Andy or anybody has something to say, but when we do NGS, we have some of these unreported data that may or may not include EWSR1, right?
So to that point, and Matt, you might have to remind me, we did only the DNA NGS for this project, correct?
I
Yeah, we
believe so.
did.
Yes.
Yeah, so what Alessio is alluding to would have to be on the NGS RNA fusion panel. So that's unfortunately one of those details. Molecular is hard, right? We got to test everything. There's sometimes different types of alterations need different types of tests, and
Right.
sorry.
No, it's okay. It was just a thought. Okay.
That's
Well,
what, man.
unless there's one more comment, I think this is a very good place to round off for today. So congratulations, Matt, and of course, Mohammed from last week. We are just so proud of you guys and the quality and the confidence of your presentation. We are looking forward to seeing you do great things in the future. So congratulations again. And everyone, have a wonderful day.